relief. With his diploma in palliative medicine from India and Cardiff and masters in palliative medicine from Cardiff, he is overseeing the clinical services and academic and research works of Pallium India with extensive 15 years of experience in palliative medicine to his credit. So, Sunil sir, without much delay, it is over to you for the session. Sunil sir, you are not audible.
Am I audible?
Yes, sir. Okay.
Okay. Can you unshare the screen, Supriya?
Sure, sir. Sure.
Yeah. We already talked about the opioids. Opioids used for mild to moderate pain as well as moderate to severe pain. But what is remaining is the opioid, one opioid which we use in third step of WHO analgesic ladder, that is methadone. We covered morphine and fentanyl, which are the other orally available opioids in the step 3. Not orally available. Fentanyl is, as you know, it is available as transdermal fentanyl patch as well as injection. So, okay. So we are trying to cover the pharmacology of methadone, and many of you might have heard about the risk associated with methadone. So we will see is it really true, and how can we balance between the benefits and risk of methadone. And while the patient is on methadone, we have to monitor the patients, and even before starting we also need to verify certain facts. So we have to have some parameters to monitor the patient. Then it is very common that even after the sessions, doctors doesn't get appropriate patient for starting methadone. So we need to understand which patient would benefit from starting methadone. So selecting the appropriate patient would be an important step in initiating methadone. And most importantly, how can we convert an opioid into methadone? Okay. So regarding methadone pharmacology, um, methadone is available as a mixture of S-methadone and R-methadone. So the available methadone in India is an isomer of S-methadone and R-methadone, and it acts on all opioid receptors as agonist. So mu, delta, kappa. So I would like to ask you, on which receptor does morphine acts? Anybody?
Mu receptor, sir.
Yeah, it's a mu agonist. Sripriya, is our poll ready?
Sir, 8 questions only, sir, as of now.
Okay, I think we will go with that first, and then we will come back to the presentation.
Okay, sir, give me a moment. I'll be sure.
Okay. So first of all, I will show you some questions about methadone, which will give you an overall idea about methadone, and then we will walk through the presentation. Okay. So we were in the slide. So as I told you, methadone is an isomer of R-methadone and S-methadone. And uh, morphine acts on mu receptors. It's a pure mu agonist. But in case of methadone, it acts on all opioid receptors, mu, delta, and kappa as an agonist. Okay. So it can produce pain relief by acting on all the opioid receptors. But at the same time, when opioids act on opioid receptors, it will also have side effects. Uh, so this is another important point. Methadone has NMDA antagonistic activity. That is N-methyl diaspartate antagonistic property. And we know that ketamine is another medication which has useful NMDA antagonistic activity. And this is another property. It acts like tricyclic antidepressants. So tricyclic antidepressants acts by inhibiting the reuptake of noradrenaline and serotonin. So methadone also has this property of tricyclic antidepressants. But the another property is it blocks the human either agogo related gene, that is HERG. And this HERG, and that is human either agogo related gene, um, is there in all the smooth muscles, but most abundant in cardiac smooth muscle, that is on myocardium. So while inhibiting HERG, it can increase the QT interval, and it can lead on to torsade points, and which will lead to can lead to sudden death of the patient. Okay, so these are uh, four mechanism of action of methadone. And we will look at the clinical impact on action due to various mechanism of action. First, we talked about it act as an opioid receptor agonist. So because of this, it will have agonistic effect as well as it will produce analgesia. But uh, it can also have the same side effects as that of other opioids. So sedation, constipation, nausea, vomiting, urinary retention, pruritus, all this can occur in case of methadone also. And the next mechanism of action is it has an NMDA antagonistic action. So you can see here there are four patients, patient A, B, C, and D, and they are on thousands of milligrams of equivalent doses of morphine. So you can see the patient A is on about 12,000 milligram of morphine, and patient D 1,500 milligram of morphine. So when all these patients, and these patients didn't had a proper pain relief, but when all these patients were started on methadone 10 milligram TID, that is 30 milligram per day, all of them attained very good pain relief. So how is this possible? It can anybody tell me what is tolerance?
So higher dose of the same drug is required to produce the same effect.
Yeah. So probably these patients who are on 12,000 milligram of morphine, 1,000 milligram of morphine equivalent, all these patients might have had the problem of tolerance, and that's why they had this much dosage of equivalent doses of morphine. So NMDA is one of the receptor involved in the development of tolerance. Okay, so that's why when all these patients started on equal doses of, that is 30 milligram of methadone, all these patients got good pain relief, and this is because of NMDA and NMDA antagonistic property. What would be the other benefit due to NMDA antagonism? Anybody? Okay. So you know that ketamine is used for pain relief, especially when patients have central sensitization um, and neuropathic pain. Methadone can also be used if the patient has complex neuropathic pain. And we know that it prevents and reverses the tolerance. So for prevention of tolerance also, we can add small dose of methadone. But once the patient is on higher doses of other opioids, you can reverse it by giving methadone. And another clinical impact is its action, like tricyclic antidepressants. So we know that tricyclic antidepressants are one of the mainstay in the treatment of neuropathic pain. So methadone can be useful in treating complex neuropathic pain, but it can also have another side effect because of this, which is known as serotonin syndrome. So this is not only applicable to methadone, but if you remember, what is the mechanism of action of tramadol? Anybody? It is a mu receptor agonist, but it has another mechanism of action also. It it also has a tricyclic antidepressant like action. Okay, so if any drugs which has a tricyclic antidepressant like action is given along with any of this medication which is shown here, it can produce something called a serotonin syndrome. And the chance of serotonin syndrome is high with fluoxetine, sertraline, paroxetine, MAO inhibitors, clomipramine, etc. And this is low with the metazapine, desipramine, nortriptyline, etc. Um, just keep in mind that there is something called a serotonin syndrome. I haven't seen any case of serotonin syndrome. And this is manifested by cognitive changes, autonomic instability, and neuromuscular changes. So, patient who is agitated, who has hypothermia, tremor, seizures, and if you are giving methadone, and you see that there is another medication like fluoxamine, sertraline, something is also there, then think of whether it is due to serotonin syndrome. And then the first three, which we already talked about, they were beneficial effect uh, of methadone. But this is one of the most fearful effect because of methadone. So the action on human either ago related gene. Um, so we told that it can increase the QT interval, and this increase in QT interval can lead on to torsade points. Once torsade points occurs, the patient can suddenly die. So there are some cardiac risk factors which we need to understand, because these are things which can increase the QT interval and even can produce torsade points. So electrolyte abnormalities like hypocalcemia, hypokalemia, hypomagnesemia, all these can produce increased QT interval. Then older people, female gender, patients with structural heart disease, and there are some individuals who has genetic predisposition to increase QT interval, or there are congenital QT syndrome which run in families. So all these are risk factors, cardiac risk factors. And another important thing that you have to notice, when the dose of methadone is higher, it increases the cardiac toxicity. But the one of the most important point, uh, which usually the doctors say why the patient is not started on methadone, is because of the fear of producing torsade points. But what you have to understand is most of the studies on torsade points and patients' death is on patients who are undergoing um, oral substitution therapy with methadone. So methadone is not only used as an analgesic, it is also used for opioid substitution therapy in opioid dependence. So in India, methadone is used as a substitution therapy even before it started as using for analgesia. The methadone is given permission to be used as an analgesic since 2018, I think. But even before that, methadone was used as for treating dependence. Okay, so here this is a prospective study which was conducted by MD Anderson Cancer Center, which is a very famous palliative care center at US, and they did a trial on 100 patients who was started on methadone, and they looked at ECG when they started the patient on methadone, then after 2 weeks, 4 weeks, and 8 weeks. And what they found was they couldn't find out any Torsade points or ventricular fibrillation, which can lead on to death. But there were some dropouts from the study, but even then they used methadone in the dose of 40 to 50 milligram. That was the maximum dose. So they couldn't find out any patients who developed Torsade points or ventricular fibrillation. So this is one study which we can point out to indicate that when you use methadone at lower doses, the chance of Torsade points or ventricular fibrillation are very, very less. And you can see there are many one of the important thing about methadone is that it has a lot of drug interaction. So it interacts with a lot of medication which can either increase the level of methadone or decrease the level of methadone. Okay, so these are medication which can increase the QT interval and can also produce Torsade points. So just see the antibiotics, the fluoroquinolones, and macrolide antibiotics, that is macrolide, azithromycin, erythromycin, clarithromycin, those group. Then fluoroquinolones, ciprofloxacin, levofloxacin, all the floxacins. And then SSRIs, citalopram, all the escitalopram, then atypical antidepressants like fluoxetine, sertraline, all those can produce or they have a definite risk while you combine with methadone. And you can see ondansetron, which is commonly used nowadays for treating nausea and vomiting. It has also a definite risk factor of increasing QT interval and Torsade points. So when you prescribe methadone, see whether there are medications which can increase the QT interval or which has the potential to produce Torsade points. So we will move on to some of the pharmacokinetics of methadone. Methadone is absorbed from the upper small intestine, and you can see the bioavailability is about 80%. But in case of morphine, it is about 20 to 30%. And morphine is not advisable to give sublingually, but methadone can be given sublingually because it is fat soluble, and it can also be administered per rectally. Even injectable preparations are available, but in India we don't have injectable preparation, we have only oral preparation. So the metabolism happens in mainly in liver, and this is what happens to methadone, and this is one of the important things that you need to understand while you learn about methadone. So when you administer methadone, it is absorbed into the blood, and it will be seen in blood for 2 to 4 hours. I'm talking about a patient who is whom we are going to administer methadone for the first time. Okay, so the methadone will be absorbed into the blood, and that will be there in the blood for almost 2 to 4 hours. But after that, what happens? It will immediately go into the tissue binding sites, and uh, then it will disappear from the blood, and it will go into the tissue binding sites. So you can see these are the tissue binding sites. And when the tissue binding sites are saturated, then a fraction of methadone will be liberated into the blood, which will give pain relief. So once the tissue binding sites are saturated, then only methadone will be liberated into the blood, and that will give a sustained blood level. So for a first few days, the saturation will not happen. So it will take about 5 to 7 days for this saturation to occur. Okay, so you can see now the tissue binding sites are saturated, and then the free fraction is liberated into the blood. So this will take about 5 to 7 days. So what is the significance of this? When you start a patient on methadone, you have to wait for about 5 to 7 days for a patient to have good pain relief. So it is not like morphine. Morphine, it will take only 24 to 36 hours to have a sustained blood level. But in case of methadone, it will take about 5 to 7 days. And if the patient is elder, and if the patient has liver problem, it may take more than this, up to 2 weeks it can take. So you should not increase the dose of methadone till 5 to 7 days. And as I told you, it is metabolized extensively in liver. And if there is biliary obstruction or hepatic dysfunction, we have to wait for more days to have a sustained blood level, up to 2 weeks. And there are various cytochrome enzymes involved in the metabolism, and cytochrome 2B6, 2D6, 2C19. And these are the major enzymes involved in metabolism of methadone. So because there are various cytochrome enzymes involved in metabolism, it can also, as I told you, it will have various drug interactions. So I'm talking about a few medications which you should be careful, because that will definitely alter the methadone level in the blood. So cytochrome P inhibitors, these are grapefruit protease inhibitors. What are protease inhibitors? Anybody?
Antiretroviral drugs.
Yeah, antiretroviral medications. Then azole antifecals. The commonly used one is fluconazole. Then cyclosporin, cimetidine, macrolide antibiotics, azithromycin, which is used commonly, amiodarone, and non-DHP calcium channel blockers. So these all are strong CYP inhibitors. So if you give this medication along with methadone, and the level of methadone can be increased in the blood. So you have to actually reduce the dose of methadone by 25%. And there are some cytochrome P inducers which can reduce the methadone levels in blood. These are phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, carbamazepine. So phenytoin and carbamazepine, these are, and phenobarbital and smoking, these are common inducers which can reduce the level of methadone. So if you are giving this medication along with methadone, you have to closely monitor the patient for any withdrawal symptoms, because you are reducing the level of methadone. And these are medication either which can increase or reduce the methadone levels. So on the left hand side, you can see there are a lot of medication which can increase methadone levels, and on right hand side, the medications which can decrease methadone levels. So what you have to understand is a lot of medication which we usually use in palliative care to treat symptoms uh, are there in both of the list. So you just see citalopram, amitriptyline, escitalopram, omeprazole, pantoprazole, cotrimoxazole, erythromycin, fluconazole. So these all are common medications which we use in palliative care. So who are the appropriate candidates for methadone, or for whom should we start methadone? So methadone can be used as an adjunct. So can anybody tell me what is an adjunct? What is an adjunct? Anybody? Something added to increase the potency. Yeah, but a more clear definition.
Actually, it potentiates the analgesic action of the if it is prescribed along with, but it itself is not an analgesic, but when used along with that, it potentiates the analgesic action.
Yeah. So adjuvants are those medications whose primary action is not pain relief, whose primary action is not pain relief, but is helpful in some painful condition. That's how tricyclic antidepressants become an adjunct. Tricyclic antidepressants' primary action is to treat depression, but it is helpful to treat neuropathic pain. Okay, so that is what mean an adjunct. But methadone itself is an analgesic, isn't it? So this is little bit confusing when a methadone can be used as adjunct. So what they mean is when you give methadone along with other opioids. Suppose a patient is on, I think today we had a patient who has um, who had, I think, gastrointestinal stromal tumor, and the patient was on 40 milligram of morphine every 4 hourly. But the patient has pain in between, um, and when the dose of morphine is increased, she has toxic symptoms. So we were unable to increase the dose of morphine. And what we did was we added 1 milligram of methadone every 8 hourly for this patient 10 days back. So when patient came today, she had very good pain relief. There is no toxic symptoms. So when methadone is used with other opioids in small doses, it is called as an adjunct. That's what adjunct refers to in literature regarding methadone. Okay. Then pain refractory to other opioids. So we know that all the patients will not get good pain relief with morphine or fentanyl or any other opioids. So if they doesn't have proper pain relief with other opioids, you can switch over to methadone. And methadone is excreted mainly by bowel, a part by kidney. But even then, it is considered to be safe in patients with chronic kidney disease. So if a patient has severe pain who has chronic kidney disease, then methadone is a good choice. And methadone, the duration of action is very long compared to morphine. Morphine can act only for 4 hours, but methadone can act for 8 to 12 hours. So if a patient needs a long-acting opioid, methadone would be a good choice. And we already talked about opioid tolerance. We saw that patients on thousands of milligrams of morphine, and when added or replaced with methadone, all of them had very good pain relief. And there is something called opioid-induced hyperalgesia, which can occur in very few patients. But in that case also, methadone can be used. Then, if the patient has opioid-induced toxic effects like delirium, myoclonus, extreme drowsiness, then you may switch over to methadone. And if the patient has allergy to other opioids, then methadone is a choice. So these are the general indication to start the patient on methadone. So how should we monitor the patient? So first and foremost thing is when we say monitoring a patient, the monitoring should depend on the goals of care for that patient. If a patient is um, sent to us only for comfort care, then the monitoring need not be too aggressive. But if the patient is getting a curative treatment, the monitoring should be aggressive. So what are the basic things which we should do when we start a patient on methadone? So first of all, you have to take a ECG. So you have to look for QT interval, actually corrected QT interval. Okay, so there are many apps by which you can get corrected QT interval. And you have to do electrolytes like potassium, magnesium, and calcium, because I told you hypokalemia, hypomagnesemia, and hypokalemia can cause increased QT interval. And then we need to repeat ECG after 2 to 4 weeks of initiation of methadone. And then suppose you increase the dose of methadone and reached to 30 to 40 milligram per day, then you have to repeat. And then you increase, and when you reach 100 milligram per day, take another ECG and see the QT interval. And if the patient has, suppose you have added some medication which can increase the QT interval, then you have to take another ECG. So these are the factors, or electrolytes and ECG are the a few parameters by which you have to monitor the patient. And this is the preparation available in India, both tablets as well as syrup. But for the last 1.5 years, only syrup was available. But I heard that now tablets, they have manufactured tablets now. Previously, tablets were available in 2018, but then that went out of stock. But now the tablet is available. It is 5 milligram. Okay, and syrup it contains 5 milligram in 1 ml. Okay, next we will move on to methadone conversion. So can anybody tell me, suppose a patient is on 300 milligram of tramadol. What is the equivalent dose of morphine that patient needs? 300 milligram of tramadol. What is the equivalent dose of morphine? Okay, which says 30 milligram. Anybody else? 30. 3 mg. Okay. Suppose the patient is on 100 milligram of tramadol. What should be the equivalent dose of morphine? 100 milligram of tramadol. 10 milligram. Okay. Yeah. So the potency of tramadol is 1/10 as compared to morphine. So 300 milligram divided by 10, it is 30 milligram. Okay. So 100 milligram of tramadol is equal to 10 milligram of morphine. Yeah. But it is not true in case of methadone. It doesn't have a linear conversion ratio. So when the patient is on 100 milligram of tramadol or 300 milligram of tramadol, you took the conversion ratio as 1:10. But in case of methadone, there is no linear conversion ratio. Okay, and if you look at the literature, there are many methods available to convert from opioid to methadone. Um, but we follow a simple method, which is known as white paper consensus method. You can see this is a method which was came in Journal of Pain and Symptom Management in 2019. And according to this, if the patient is opioid naive, or if the patient is taking less than 60 milligram of oral morphine equivalent per day, you can start the patient on 2 to 7.5 milligram of methadone per day. Okay, 2 to 7.5 milligram of methadone per day. But if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if the patient is less than 65 years old, the conversion ratio is 10:1. That is 10 milligram of oral morphine is equivalent to 1 milligram of methadone. If the patient is taking more than 200 milligram of oral morphine equivalent, or patient is more than 65 years, conversion ratio is 20:1. So this is what I told you. There is no linear conversion ratio in case of methadone. The dose or the conversion ratio varies according to the dose of morphine. Okay, so if you want to convert an opioid to methadone, first of all you convert into morphine, and from morphine you have to calculate the dose of required methadone. And another important thing is that whatever be the dose of morphine equivalent the patient is taking, never start patient more than 30 to 40 milligram. We saw that the patient was on 12,000 milligram of oral morphine equivalent, and those patients started on 10 milligram 8 hourly, that is 30 milligram per day. Then also the patient had good pain relief. So that's why the recommendation is never start more than 30 to 40 milligram of methadone per day at the initial step. And and if you want to increase the dose of methadone, so this is the recommendation, and this increase can be done only after 5 to 7 days, not on the second or third day. So you can see if the patient is taking less than 30 milligram of methadone per day, you can increase 5 milligram per day. Okay, and wait for another 5 to 7 days before increasing the dose. If the patient is taking more than 30 milligram per day, you can increase 10 milligram and wait for another 5 to 7 days before increasing. I told you that if the patient has hepatic impairment, or if the patient is elderly, then you have to wait for 10 to 14 days before increasing the dose of methadone. So we will see some of the real patient stories where we convert an opioid to methadone. Okay, so this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa, but he also had a second primary papillary of carcinoma of the thyroid, for which he underwent surgery and radiation. But after 1 year, he had a level 2 nodal recurrence, for which he underwent surgery. And when the patient came to us, he was like this. You can see the patient. He had very severe pain. He was describing that pain starting inside left ear, going to lateral side of forehead, and then to submental region. And he described it as pricking pain 10/10. You can see the distribution of pain is in the mandibular, the dermatome supplied by the mandibular division. And then this patient underwent extraoral mandibular nerve block thrice from an outside institution, but he didn't had any pain relief. So uh, they started him on injection morphine, but they couldn't continue with it because of toxicities. And then started on tab morphine like this: 10 milligram, 15 milligram, 10 and 30 milligram with 10 milligram SOS. Even with this, he had toxicities and no pain relief. And they also tried him on various adjuncts without any pain relief. So these are the medications when this patient came to us: morphine, pantoprazole, ciprofloxacin, acetalopram, serratiopeptidase, diclofenac patch, paracetamol 650 milligram. So can anybody tell me what should we do for this patient? What is the next step? What would you do if this patient comes to you? Add paracetamol. Um, yeah, we can add paracetamol, but uh, we can see this patient has a neuropathic pain, and the paracetamol may not be an option. Increase the morphine dose. Yeah, patient has morphine toxicities. That's why they couldn't increase the dose of morphine. And you can see they have adjusted the dose of morphine like 10, 15, 10, and 30. They were giving only 4 times a day. I can see Dr. Sangeeta says add methadone 1 milligram TID. Okay, what else can be done? Okay, suppose we plan to start this patient on methadone. What are the indications to start methadone in this patient? We told that there are certain patients who are appropriate to start methadone. So what are the indications in this patient? Fentanyl or bupivacaine patch. What are the indications? That's what we have to uh, see when a patient comes. Morphine toxicity at higher dose. Yeah, that's true. What else? Okay, it appears like a complex neuropathic pain. I told you that patients, because of the NMDA antagonistic property as well as tricyclic antidepressant property, methadone would be a good medication in complex neuropathic pain. Then, as you told, the patient has morphine toxicities and not responding to morphine. Okay, so these are a few indications to start patient on methadone in this patient. So you decided to start this patient on morphine. But before proceeding, what all should you do? Before starting, what should you do? ECG, yes. ECG and electrolytes. Yeah, that's true. Anything else? So we have to get, okay, we have to get a history of is there a history of sudden unexplained death in family? Because this might be due to congenital QT syndrome, which can run in families. So you have to ask them, is there a history of sudden unexplained death in your family? Okay. Then one of the other criteria for starting methadone is the patient should have a reliable caregiver. It is not like morphine. Whenever you give morphine, the effect can be seen within 24 hours. But the effect of methadone will be seen only after 1 week. So it is important to have a reliable caregiver. Okay. So these are the two prerequisites for starting a patient on methadone. And then, as you told, ECG and electrolytes. But it is also important to note what is the goals of care for this patient. This patient has had two primary cancers, and which has recurred, and the oncologist told they cannot, this patient cannot be undergo any oncological intervention. So the goals of care is now purely palliative care, comfort care only. So you need not actually do ECG or electrolytes for this patient. But if you want to do, then ECG and electrolytes can be done. So do you have any concerns with the present medication? Because you are going to start the patient on methadone. So these were the medication the patient is on when he came to us.
So patient is taking ciprofloxacin and escitalopram.
Yeah.
So ciprofloxacin may be the enzyme inhibitor, so we need to reduce the dose. Plus citalopram is again may cause serotonin syndrome. So chances of that.
Yeah. Uh, any other medications has any interaction with methadone? Pantoprazole also have some interaction. Okay. So escitalopram, pantoprazole, and ciprofloxacin. But out of this, ciprofloxacin and escitalopram are the two drugs you have to definitely look into. So now, how are you going to calculate the dose of methadone in this patient? Can anybody tell me what would be the dose of methadone this patient requires? You can see a patient is on tab morphine, 10, 15, 10, and 30 milligram. So please calculate the dose and tell me. Two 2.5 milligram 8 hourly. What is the total dose of morphine patient is getting? 10, 15, 10, 30. That is 65, isn't it? Yeah. So what should be the dosage? 2.5 milligram 8 hourly. Okay, let's see. So total oral morphine equivalent the patient is taking is 65 milligram. So the patient's age is 37 and the oral morphine equivalent is between 60 to 199. So what would be the conversion ratio? It is 1:10, isn't it? So 65 divided by 10, it is 6.5 milligram. So maybe you can start, if you have only tablet, you can start with tab morphine, tab methadone, 2.5 milligram BD, or syrup methadone, 3 mg BD or 2 mg TID. Okay. Are you okay with this? Do we need to give any other medication along with this? What should we do with morphine? So we already told that methadone will take about 5 to 7 days to have a sustained blood level. So till that time, you have to continue with the previous opioid which the patient was taking. But it is not on a continuous basis. You would give it on a SOS basis. Okay. So have morphine 10 milligram Q4H on SOS basis. Okay. That means suppose at 6 a.m. You gave 2.5 milligram of methadone and you will ask, do you have pain? If the patient has pain, you will have morphine 10 milligram. If patient doesn't have pain, you will not give methadone. So 10 o'clock, you can ask the patient, same, do you have pain? If yes, give morphine 10 milligram, or if not, don't give. That's what a 10 milligram Q4H means. Okay, it is not on a 10 milligram. It is not like regular prescription 10 milligram Q4H and SOS. It is not like that. It is Q4H SOS. So in this patient, you can have methadone, morphine on an SOS basis, then paracetamol 6 hourly. As you told, ciprofloxacin should be replaced. He was given amoxicillin 500 milligram TID. Then we have to continue with laxative. Now we will move to another patient. So 39-year-old woman with carcinoma pancreas, stage 4 disease with liver, lung, and splenic metastasis. So she received 5 cycles of chemotherapy and she was having various symptoms. And the oncologist told her that the disease is not responding to chemotherapy. So he asked her to stop it. So she was receiving palliative care from that oncologist. So you can see this is the pain pattern. It starts on the left lateral chest, goes to the back, and this pain is there for 2 months. She described it as a continuous pain and stabbing. The pain varies between 8 to 10 by 10, and the palliating factor is morphine plus tramadol plus paracetamol. When she take these three, her pain comes down to 8 from 10 by 10. But she has myoclonus, very frequent myoclonus, and she was on these medications: morphine 20 milligram every 6 hourly, injection tramadol 100 milligram IV TID, paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisacodyl 5 milligram 2 HS. So, is there any indication to start methadone in this patient? Anybody? Pain is not relieved. Yeah, pain not relieved by morphine. Yes. What are the other indications?
Opioid-induced ADRs like myoclonus.
Yeah. Yes. Okay. So patient has myoclonus, which indicates she has opioid toxicities. It looks like neuropathic pain. So do we need to do any investigations? This patient has a stage 4 disease, not planned for any oncological interventions. So you need not do ECG or electrolytes, but you can get the history of sudden unexplained death in the family, and also ask if there is any reliable caregiver who can administer methadone for the patient. So what is the dose of methadone required for this patient? So these are the medications. Okay, oral morphine equivalent is 80 milligram. Dr. Narendra says 4 milligram 2 hourly, 12 hourly. Okay, 4 milligram, 2.5 milligram TID. Okay. So you have to actually convert all the opioids to morphine. That's why it is called as oral morphine equivalent. So patient might be on various opioids, sometime on morphine, tramadol, fentanyl. So you have to convert all these opioids into morphine. Okay. So let's look at here. So this patient is taking 20 milligram morphine every 6 hourly. So that will come to 80 milligram. But she's also taking tramadol, isn't it? So she's taking 300 milligram of tramadol. So the equivalent dose would be 30 milligram. So total oral morphine equivalent would be 80 plus 30. That is 110 milligram. So what would be the conversion factor? It would be 10:1 because the age is 39 and she is taking oral morphine equivalent between 60 to 199. So the oral dosage is conversion ratio is 10:1. So 110 divided by 10, it is 11 milligram. So you can start with tab methadone, 5 milligram BD. And this, do you have any concerns with any medications? Which one? Tramadol, amitriptyline. Yes. Okay. Tramadol we already converted into methadone, isn't it? So start with methadone 5 milligram BD, morphine 20 milligram QFRH on a SOS basis, paracetamol every 6 hourly, gabapentin continued. And as you told, amitriptyline, it might be a concern, but when you become experienced, then you will understand more about drug interaction and how it works. So when we started methadone for our first patient, we were very afraid, and even we were looking at a chance. How can we not start a patient on methadone? So that's what we did when methadone was available in 2018, because we were afraid of the side effects of methadone. We have heard about the QT interval prolongation, dosage points, drug interaction. All were making us afraid of starting methadone. But when we become experienced, then it was easy for us. So in this patient, we continued with amitriptyline. This patient has got good pain relief for almost 2 months, after which she died. So we have another patient, 40-year-old man, advanced malignancy of the lung with spine metastasis, and he has at T12 spinal cord compression. He is complaining of burning pain on both lower limbs, which is continuous. Pain score is 9/10. He is on 40 milligram of morphine 4 hourly, no pain relief. Suppose you want to start this patient on methadone, what would be the dose? Okay, 12 milligram. Okay. So this patient is taking 40 milligram 4 hourly. That means 240 milligram. So what is the conversion factor? It is 20:1 because the patient is taking more than 199, more than 200 milligram of oral morphine equivalent per day. So it is 12 milligram. So you can start either 5 milligram BD of tab methadone, or if it is syrup, 4 milligram TID. Continue morphine on 4 hourly SOS basis. And if you want to know more about cytochrome interaction, and there is you can go to this website, and crediblemed.org is something in which you can get medication which can cause QT prolongation. Methadone is a very useful medication if you use it properly. You might have heard about many of the side effects of methadone, including QT interval prolongation, torsade points, drug interactions. But if you are going to use it for a needed patient or an appropriate patient, it can give good pain relief. So the basis is you have to select the patient for starting methadone. And when you start methadone, um, there are various methods available to convert from an opioid to another. But the one method which I told you is white paper consensus method, which is very simple method. And it is very conservative method of converting an opioid to methadone. So use it. And if you are using morphine, and if you have an RMI status for your institution, then you can get methadone with the same RMI status. And most importantly, when you start a patient on methadone, wait for at least 5 to 7 days before increasing the dose of methadone. Okay, thank you. If you have any doubts, you can ask.
Thank you, sir. Thank you so much for that very comprehensive session. Dr. Indira had requested that she join late, so kindly tell the conversation factor at the end of session. I think we will be sharing the PPTs as well.
I think can any of you give a summary of the conversion from an opioid to methadone? Anybody? We already gone through 3 case histories, so all of you know. How do you convert an opioid to methadone? So can I ask Dr. Vicky?
Good evening, everyone. I think what I remember actually from 60 to 199, the conversion rate is 10:1, and provided the age is less than 65 years, and uh, uh, and the age is more than 65 years, or when the dose is more than 200, then the conversion rate is 20:1,
Yeah, that's
and
yeah.
uh, less than 60, I am actually forgetting
It's
that ratio.
2 milligram to 7.5 milligram per day.
Okay, thank you.
Thank you, Dr. Vicky. Yeah. Are there any doubts?
If there are no more doubts, I think Sunil sir, as you know, this is our last session for the FCPM,
Hmm.
and we'll be taking the verbal feedbacks as well.
Yeah.
Sir, before that, I think we have our chairman, Dr. Rajagopal, joining us for a short time with this cohort, as he has not addressed this batch so far. So,
Okay.
sir, if you could say a few words and then hand over to him, sir, that would be.
So I think most of you would know Dr. Rajagopal, um, who is the founder chairman of Palim India, and he started his work from Calicut, and then moved on to Trivandrum and established Palim India. And in addition to chairman of Palim India, he is the director of Trivandrum Institute of Palliative Sciences, and he also received Padma Shri in 2018, and recently a book, Walk with the Weary, has been released, and there are many more things to say, but I'm stopping here. So welcome, sir.
Thank you, Sunil. Thank you, Sripriya. Hello, everybody. I'm hoping to see a few smiles. It's the last day. Oh, thank you. Thank you, Shivani. There must be more smiles under masks. Good to be with you. I'm sorry that I couldn't be with you earlier. Usually, no batch escapes me. I make it a point to join you at some point during your course or other, but it did not happen. So, Sri Priya, Sunil, thank you for giving me this opportunity to say hello to everybody. I won't talk long, but to the best of my knowledge, this is a very critically important group here. Sunil, correct me if I'm wrong. These are all faculty members from various medical colleges. Friends, you are part of a revolution. You are pioneers. The healthcare system globally and particularly in India has always been disease focused. As medical students, we are taught the basic sciences so that we can diagnose and treat. Then we are taught how to diagnose and treat diseases. The treatment is almost completely disease focused. Mostly diagnose and cure, a little bit of prevention. Whereas what really people suffer from escapes attention of the professionals. It is in this context that palliative care becomes important, because we are going to treat suffering, and you have the privilege to be agents of change, because the inclusion of most elements of palliative care in the curriculum is very new in India. 2019, okay, it has not been really implemented in most parts of the country. That's the truth. So I mean, as of early this year, there were 612 medical colleges in the country. There must be many more now. I heard that even as late as a couple of days back, a new medical college was started in Kerala, and this must be happening all over the country. So, and the numbers of medical students, I understand, are close to 90,000 a year. And if all these people learn how to treat pain, how to treat other symptoms, and the learning may be revolutionary. Like I was taught that the only absolute contraindication for morphine was breathlessness. And today, morphine becomes a drug of choice for breathlessness in advanced incurable illness. So the learning points are also revolutionary. And this the medical system is gradually recognizing. There is a plastic surgeon in the city of Kochi in Kerala. And he recently wrote that we doctors live in an idealized problem-solving scientific space, while most of our patients fall through the cracks of our system, writhing in agony. We ignore the Jurassic monsters that inhabits our workspace, that is pain and death. We ignore the Jurassic monsters of pain and death while playing with squirrels and chasing rabbits. That's what he writes. And that may be a bit of an exaggeration, but the fact is, your medical education and mine, half a century back, did not equip ourselves to treat suffering. Palliative care does. And this, through you, are going to be imparted to the medical students all over the country. You set a system going, and others will, you light that candle and others will light that from you. I think you have a noble task ahead. I am glad that all of us in Pallium India had the privilege to be part of this process. I look forward to your success with excitement. I know you still have more to do, feedback, etc. I don't know if Sri Priya and Sunil will allow any questions to me, but was Dr. Indira Yadav's question already addressed? Okay, that's for the conversion factor. That can be sent to her by herself. So I don't know how the time situation is. Sunil, Sri, why don't you go ahead with the feedback session? And if you think appropriate, I can chip in
Sure, sir.
when
Sure.
there are questions.
Sure, sir. Thank you for joining us, sir. I understand your busy schedule. I have been seeing you from personally from the morning in midst of a lot of meetings, and still you found out time to join us. Thank you so much for that. So now, dear participants, this marks the end of session under the FCPM series. Of course, many of you will be going on to the FDP series, the FDP program, the Faculty Development Program, which is the flagship prestigious program of our Trivandrum Institute of Palliative Sciences, and we do look forward for that. So I will now request some of the participants to share a few kind words, if possible, honest feedback. What went good for you? What you thought could have been better, so that we could also improve ourselves. So the platform is open. Volunteers, please. You can unmute yourself and say the words. Thank you, Dr. Indra. But I believe that at this point of time, maybe if someone could unmute and share a few words, honest words.
Good evening, madam. I am very new to this. What should I say? This faculty of medicine. Very new to it, but I was very impressed with the. Actually, we did in our times we didn't need this much, but nowadays I am very impressed. Communication is very important with patients as well as patient party, which we don't do nowadays. We just don't do it. We don't. I don't think actually we have lost the way probably. Maybe the patients are more, parties more, and it is more disturbing. I don't know. But when we were junior residents, we didn't have this much of mob problems or this much of harassment of doctors or beating of doctors and all. Probably because we spoke more to the patients and the party. But now, what Dr. Kharwanda said, that anger and anger turns into rage. We have to stop that anger, which is very, very important. That is what I feel. This communication part, pain is also important, very important, but the communication with the patient and the party, listening to them, I think that is very important part of palliation, which probably we should learn. Everybody should learn.
Thank you, Dr. Sanketa, for that valuable point. So we would take it as a very positive feedback. And like you said, maybe 1 or 2 sessions more with focus on communication is what is the need of the hour, if I could interpret you correctly.
Yes. Every junior, I mean, MBBS itself, the communication should be a big chapter, big portion of medicine as such in every college, I suppose, which is very important now. Yeah.
And Dr. Sangeeta,
Yes.
I hope you are aware that from 2019, communication is officially in the curriculum. It came into the curriculum in 2017, but the students who joined in 2019 are supposed to learn it. Unfortunately, this was never there so far. So the faculty themselves are not adequately equipped. But then Sunil can tell you about what we have done, created the modules, things are available so that you can use the existing available material to teach your medical students. But absolutely, totally agreed. This is so vitally important. It was always important, even more important now. So now because there's so much of loss of trust in doctors and hospitals. Thank you.
We do have a couple of responses in the chat box as well. Dr. Kalanti had said case scenario based discussions were very useful in understanding concepts. Thank you, Dr. Kalanti. Moving on, Dr. Narendra Paliwal has expressed that grateful to Team Pallium India, all respected faculties and participants. Thank you again. Dr. Urmula has commented, thank you, Pallium India, for organizing this program, providing us knowledge regarding palliative care and sharing experiences and knowledge from different faculties and participants. Thank you. And sir, you have written something.
No, that's why I earlier quoted something. I just shared those words with everybody along with the link.
Sure, sir, sure. So we would request everyone to go through that Facebook post posted by Dr. Jimmy Matthew. Dr. Indra Yadav has a very, very useful program by Pallium India. Okay, Dr. Nilkant Sutar has updated that new CBME UG courses have many thoughtful competencies like communication skills, 8 core modules, etc. That is good. Dr. Narendra Pariwal has said that sessions on communication and ethics are demo session. Thank you so much. Anyone else would like to add any points? Or Dr. Manisha is also of the same comment that case-based discussions by faculty were very useful. Yes, we have noted that point. So we will be updating all the faculties regarding that feedback.
Moreover, ma'am, I want to just add on one thing. I want to thank Pallium India for allowing us all to attend this session from the comfort of our working places. That was the most important thing. So we could attend this online.
Thank you so much, Dr. Shivani. Yes, of course, this has been brought in, this change has been brought in by the COVID wave, I suppose, because earlier it were more of on-site trainings, and it was because of the COVID restrictions that we had to switch up to the online mode as well. So yes, of course, we also find it really like if uh, everyone could benefit from the comfort of their home, that will be good for us also. Thank you for that feedback. Does anyone else have to share any comments, thoughts? I believe everyone is in a send off mode. In that case, if no one else have to say, Dr. Neelkant Sudhar has again commented that thank you, Pallium India, for enlightening me on better pain management. Now I'm a better soldier and fighter to help my patients to decrease their pain. And I will. My prayers for better health and development of the Pallium India team. Thank you so much, Dr.
No,
Neelkant. Yes,
Priya,
sir.
before you close it, let us get at least one negative feedback. What could be improved? That's what actually helps. And
Yes,
I
sir.
found such and such thing difficult. This was the difficulty, etc. Everybody is a nice person, so nobody wants to say that. Sri Priya, I won't insist if nobody has any comment. If you want to close, okay. But to make sure that everybody gives me one more smile before leaving. Need more non-cancer case discussions. There it comes. Training compulsorily, not yet. But Dr. Neelkant, the Government of India's Ministry of Health has an organ called National Health System Resource Center. We have been working with them. They have created national level trainers and state level trainers in palliative care. So doctors have been trained to provide palliative care training. And of course, it's up to the state department to implement it. But already in 2020 and 2021, in every state, the trainers have been trained. So this facility to provide it to government hospitals can be done provided the state government goes by what the central government has provided.
Thank you, sir. Dr. Dhyan Prasad had shared that I'm new to palliative care. Being doctor is difficult to understand about palliative care. I learned difference between palliative care and treatment. Few words are really important than hundreds of medicines. Thanks, Pallium India, for this wonderful course. It is like foundation for me. Very grateful to hear those words, Dr. Khan Prasad, because that is what, at the end of the day, we at Pallium India cry for, where the relief gets to the needy people where they are. So that is what we thrive for, and that is what I think Dr. Raj will also agree to. Dr. Mrinal says, sir, it was a great chance to see and hear you live. Hope I will meet you also once again, also once in person. One point that I want to highlight that sometimes in some lectures, the faculty was fast due to the allotted time. Maybe we need more time in the lectures or 1 hour, 2 parts. Thank you so much for that valuable feedback, Dr. Mrinal. Yes, we will definitely consider that. And we will share this feedback to the faculty panel as well, so that whatever they are trying to invite to your learning gets completely delivered. Dr. Neelkam continues, because my senior old schools professors are still reluctant to giving morphine to patients. So mass sensitization is required, at least at my level. I will share knowledge to my seniors and juniors and convince them. He has said that in continuation with the government hospital.
Neelkant, you must understand that we old timers find it a bit difficult to change. It's not easy for old people to change. Maybe only by learning from examples and gentle persuasion can we effect change. This is a reality. But that is very true. There was a rather well-known oncologist abroad who said something like, we will not use the M word here. M word means morphine. He had banned. A very kind professor had once said, when his own daughter was undergoing surgery, no hard analgesics. And the same doctor later, it took many decades, then registered for a palliative care course. So we also change, but much slowly. You will have to be patient for us, and sometimes maybe bypass us and do things. Okay, Sri, I have come in late and then encroached onto your time. It's already very late, I see.
No worries, sir, because I believe that each participant would agree that it is very rarely that we get eminent personalities like you joining us and sharing your wisdom and experience. So, if anyone else has anything more to share, maybe 1 or 2 minutes more we can spare, or else I will hand over the podium to Dr. Rajagopal and Dr. Sunil for the final.
I'll hand over to Sunil happily. Thanks, Sri.
I think it was your duty to end this session.
Yes, sir. That I will do formally, but still,
So,
if
She
you
is
would like
giving
to say
you,
something more.
she is
so
giving you
thank
the
you.
honor.
It was our, as sir told, it was our privilege to have you for this session, and we hope that you will be the people who are going to lead a bunch of doctors who will come up with some palliative care minds and attitudes. So thank you for joining us for the last 20 sessions, and we will see all of you during the faculty development program.
Sunil, does everybody know that for any assistance in starting palliative care services in their own places, they are free to contact us? So please make a note of this, friends. It may be in a very small way, maybe as individuals, maybe as institutions or departments or units. If there is a possibility of starting palliative care where it's not existent, we have a division in Pallium India. It is called State Facilitation Team. They do only that, and we'll work with you very happily. Thank you.
Thank you, sir, for reinstating that. Actually, our SFT member, Miss Aarti, had taken her wonderful session yesterday only to this cohort.
Okay, sorry.
So, thank you everyone for joining in. As I told in the beginning of the session, as we told, let this be the beginning of our journey, a successful and long journey for both of us, where we as members of, we as volunteers of palliative care bring harmony to the lives of the needy people. There is a word, there is a poster which some of our faculties use in some sessions. In illness, where the I is replaced by we, it becomes wellness. So instead of the I, let us be we and bring in wellness to hundreds of lives around us. So with that note, I got a thanks, Sri. I believe Dr. Indra has thanked me. Thank you so much. It was really a pleasure knowing you all and working with you all. So, and please remember that only the sessions have come to the end. The WhatsApp group is still there. So, in case you are in any kind of queries, any doubts, any support, any help you need regarding palliative care, our team is there to help you, to support you in all aspects. So, please do feel free to reach out to us through WhatsApp or email. With that note, this is Sri Priya along with Dr. Rajagopal and Dr. Sunil Kumar signing off from the Tech Psycho Hub. Everyone take care, be happy, and spread happiness. Bye bye.